Welcome, CyberMDs, to another lecture in the Undifferentiated Patient Lecture Series. In this lecture series, the goal is to provide you with a framework for thinking about the differential diagnosis for various chief complaints and how to approach the workup that your patients with those chief complaints might need. Before we get started, please remember to like, comment, and or subscribe so that we can continue to provide free medical education resources to students all around the world. All right, let's talk about today's topic, which is chest pain. So a little bit about chest pain. It accounts for over 7 million emergency department visits per year, and that's just in the US alone. There are about 6 really life-threatening things that you don't want to miss, life-threatening diagnoses that you don't want to miss whenever a patient comes in with a chief complaint of chest pain. And so you're rapidly going to rule those out as quickly as possible, namely a myocardial infarction, and you're going to get an EKG for that, which we'll dive into a little bit later. But just know that there are hospital-specific and nationwide specific standards set for how long it takes a patient to get an EKG, and then once you have that EKG, how long it can take for that patient to get sent to the cath lab if they are having a myocardial infarction. So be aware of those guidelines at your institution and nationally as well. We're going to be using a mnemonic approach to make sure we don't miss anything in our differential diagnosis, and we're going to be using the mnemonic PET-MAC to make sure we don't miss anything. And in almost all of these letters in the mnemonic, there's going to be 2 things. The exception is going to be the E, where there will only be 1 thing in the differential diagnosis. So let's dive right in. So for P, you're going to be thinking about pulmonary embolism and pneumonia. So for these patients, you might want to ask historical questions like, have they traveled recently? Any long plane rides? Do they have a history of recent prolonged immobilization? Maybe they recently had a surgery. You can ask about histories of DVT or history of PE. Maybe if it's a female patient, you can ask about a history of pregnancy. They may be hypercoagulable from that still. Maybe they have a known malignancy, and that would put them in a hypercoagulable state. You can calculate a Wells score, or you can try and see if these patients perk out. There's something called PE rule-out criteria that you should be aware of. Look up the Wells score, look up the PE rule-out criteria, see if you can use those things on your patients to raise or lower your clinical suspicion for a DVT. With regards to pneumonia, you can ask about cough, sputum production, fever. Maybe someone around them has had pneumonia recently or has had a cough recently. Maybe they've had this cough for a few weeks. Maybe they had a viral illness and now they have this superimposed pneumonia. So ask about all those kinds of things in your history. On physical exam, you should see if this patient is tachycardic. Do they have tachypnea? Are they breathing really fast? Do they have decreased breath sounds anywhere? Or do they have crackles or rales? You should investigate for signs of DVT. Maybe they have unilateral leg swelling, unilateral leg warmth, or erythema. So those are all things you can look for on physical exam to help you rule in or rule out or be more suspicious or less suspicious of a pulmonary embolism or a pneumonia. And then for diagnostic tests, remember that for PE, your gold standard diagnostic test is going to be the CT pulmonary angiography. And then for the pneumonia, you can get a chest x-ray to raise or lower your suspicion for pneumonia. We won't talk too much about D-dimer. Just know that there's sort of this decision tree where if you have a lower suspicion, you can go ahead and throw a D-dimer. Some people refer to this as rolling the D-dimer dice and see if it's positive. And then if it's positive, you kind of have to get a CT pulmonary angiogram to make sure that this patient doesn't have a pulmonary embolism. However, if it comes back negative, then you can safely move on if you have a low clinical suspicion for pulmonary embolism. And just of note here, remember that pneumonia can also remind you to think about other airway infections. Maybe this patient has a tracheitis and they're saying that they have chest pain and it's actually a referred pain from their trachea. So just something to keep in the back of your mind as a possibility for these patients. All right, the E, again, this is the only one that has 1 diagnosis that you need to be aware of, and that's going to be esophageal rupture or Boerhaave syndrome. You can ask questions about were they vomiting or retching prior to the onset of their chest pain? Did they ingest any sort of foreign body that could have poked a hole and perforated their esophagus? Have they had any sort of caustic substance ingestion that maybe quote unquote melted through their esophagus, causing a perforation all the way through their mucosa and leading to this chest pain that they now have? On physical exam, you can maybe look or listen for Hammond sign, which is this like crunching or crackling noise that is synchronous with the heartbeat while you're auscultating. And then you can also palpate over the patient's anterior chest wall and make sure that there's no crepitus from the free air or like subcutaneous emphysema is present or not present. You can check that just simply by palpating the anterior chest wall. A lot of people will describe it as pressing in on Rice Krispies. I have seen this before, not in a patient with esophageal rupture, but this patient did have subcutaneous emphysema one time, and it does sort of feel like you're pressing down on Rice Krispies. So that's something you can look for on physical exam as well. And then as far as diagnostic tests go, you can get a chest x-ray to evaluate for any sort of subcutaneous emphysema. You can get an esophagram. Make sure that you use a water-soluble substance if you're going to do the enema, or not enema, just the esophagram. And make sure that's typically going to be called gastrographin. On tests, a lot of times they may try to trip you up and say, or give you the option of a barium swallow test, and barium would actually be really irritating and could cause a mediastinitis if you swallowed barium and you had an esophageal rupture. So make sure you use a water-soluble contrast, also commonly referred to as gastrographin, is one of the options there. And then you can also do a CT of the chest to further evaluate whenever you're doing these imaging studies, to see if there's any extravasation of this water-soluble contrast, to see if there's any subcutaneous emphysema, to see if there's any mediastinitis, maybe some other sort of infection going on in the anterior chest. You can check for all those things with a CT scan as well. Okay, so the next letter in our mnemonic is T, and this is going to stand for tension physiology. Could be from a really bad hemothorax or a really bad pneumothorax. And then the other differential diagnosis to consider is throw up or GERD in these patients under the T letter. So for tension physiology, maybe you are asking yourself, does this patient have a history of trauma to the chest? Do they have sudden onset pain, or is it relevant to eating? You know, maybe you're more suspicious that this is an etiology from GERD. And so you're asking yourself, is this sudden onset? Is this due to trauma? Or maybe you're saying, does this patient have chest pain right after they eat? Or do they have symptoms of reflux in the past? Have they ever been diagnosed with GERD? On physical exam, you're going to be looking for decreased breath sounds or absent breath sounds on one side. You can look for hyperresonance to percussion if you have a suspicion for a pneumothorax, or you can have dullness to percussion if they have a hemothorax. And so those are things to consider on physical exam. Maybe on GERD they have some epigastric tenderness, and that's what they're calling their chest pain. When you actually palpate their epigastrium, say, oh, that's actually where it hurts the worst, and then it just kind of hurts in my chest. And so maybe that makes you a little bit more suspicious that this is etiology of GERD for their chest pain rather than tension physiology or some other concerning diagnosis. As far as diagnostic tests go, you can get a chest x-ray to rule out the pneumothorax, and you can do this upright or supine, especially in a trauma patient. They're often going to be supine when they get their chest x-rays. And then if you have a trauma patient who's stable and they end up going to CT, you can evaluate the CT scan. If they get a CT of their chest, you can evaluate the CT scan for evidence of pneumothorax or hemothorax as well. So those are all things to consider, again, in patients with chest pain. Next up is going to be the letter M, and that's going to stand for myocardial infarction, which is really going to be reminding you to think about all ACS processes. And then myocarditis, which is going to remind you to think about pericarditis as well as endocarditis. So historical questions you can ask patients with regards to these diagnoses, maybe is the chest pain radiate to the left arm or the right arm? Does it go to the jaw? Is it associated with exertion? Does it get better with rest? Have you had a recent viral illness? Do you have fevers or night sweats? Have you had any weight loss? Have you ever been told you have a heart murmur anytime recently? You can also, on physical exam, listen for that heart murmur if you suspect some sort of endocarditis process. You can listen for a friction rub for pericarditis. As far as diagnostic tests go, you're going to get an EKG on every single patient who comes in and complains of chest pain. You have to rule out myocardial infarction. You have to rule out ischemic processes that will necessitate a cardiac consult and necessitate this patient going to the cath lab immediately. You should really be worried about these patients, and you should want to get that EKG as soon as possible to rule out any sort of typical ischemia, which is going to be your in-STEMIs and your STEMIs, and also to rule out atypical ischemia, which is going to be things like left bundle branch block that meets Scarbosa criteria, or Wellens, which are all these EKG patterns that you can look for that are atypical ischemic patterns. So make sure you get an EKG, and oftentimes these patients will also get delta troponins, which means you get a troponin as soon as you can, and then it comes back. You see what it is a little bit later, a few hours later, and you make sure that their troponins aren't uptrending, which would make you more suspicious that there is some sort of cardiac damage, possibly an ischemic process occurring, and that would, again, increase your suspicion for those things. So possibly get a delta troponin. You're typically going to get your CBC and CMP as well. Make sure they're not anemic. Make sure there's no severe electrolyte abnormalities causing their chest pain or putting them at risk for an arrhythmia. You're also going to get an echocardiogram, usually POCUS, in the ED, point of care ultrasound at the bedside. Make sure there's no ventricular wall motion abnormalities. Make sure there's no signs of ischemia on that ultrasound. Make sure they have good squeeze, as we call it sometimes. Make sure they have a good ejection fraction. Make sure that they are pumping blood adequately, and this can also help you rule in or rule out a pulmonary embolism, because you can look for signs of right heart strain. You can also get a cardiac MRI, or you can get biopsy if you think that this is myocarditis. So those are all tests that you can order to help you rule in and rule out these life-threatening diseases that can kill our patients who come in complaining of chest pain. Okay, second to last is the letter A. So for A, you're going to be thinking about aortic dissection and attacks, i.e. panic attacks and anxiety attacks. So for these patients, you can ask questions like, was the onset of the pain sudden? Does it feel like it's tearing? Oftentimes these patients describe this pain as a tearing chest pain. Does it radiate anywhere? Does it radiate to the back specifically? That's maybe a little bit more concerning for an aortic dissection. And then if you think that this is only due to anxiety or panic attacks, which you should never think that when a patient first comes in with chest pain. You should always rule out all these other dangerous things first, but maybe there's an element of anxiety or panic to this patient's chest pain. So you can ask about things like recent stressors or palpitations or a sense of doom, and those are all things to ask once you've ruled out these really dangerous, life-threatening things. On physical exam, you can get blood pressure in both arms to see if there's any sort of severe discrepancy between the limbs. You can look for neurologic deficits. Oftentimes, these patients with aortic dissections can sometimes come in and they'll have a focal neurologic deficit to accompany all their other symptoms of chest pain. So that's something to keep in mind. And then you can look for tachypnea or tachycardia. Maybe that would bump your suspicion up that this patient was having an anxiety attack or a panic attack if everything else was normal in those patients. And then for diagnostic tests, you can do CT angiography. That's going to kind of be your gold standard to make sure this patient doesn't have an aortic dissection. Occasionally, you can see an aortic dissection on ultrasound, but the data on that's not great. So I wouldn't rely on that in the emergency department or any other setting to rule in or rule out a aortic dissection. I would really make sure this patient was stable enough to go to the CT scanner so that we could evaluate the entire aorta and see exactly where it's at, what type of aortic dissection it is, and how to manage it moving from there. And then if everything comes back normal and your history is very in line with anxiety attacks and panic attacks, you can reassure these patients, you can discharge these patients, and give them good return precautions. Make sure they know that the emergency department's open 24/7, if they need any access to healthcare, if the chest pain comes back and they are really worried for their life again, they can come back at any time. So if you're going to discharge a patient from the emergency department who has chest pain, make sure that you give them really good return precautions and make sure you've ruled out everything that can possibly kill them as soon as they walk out the door, and make sure you didn't miss anything that can cause chest pain, anything serious. Okay, the last letter is C, and that's going to stand for cardiac tamponade and costochondritis. That costochondritis is going to remind you to think about other musculoskeletal things. Maybe it's somebody who just started exercising and they're very sore. And so that's kind of what I'm getting at when I say other musculoskeletal things. So for cardiac tamponade and costochondritis, you can ask historical questions like, do you have any recent trauma or any recent cardiac surgeries that could lead to this cardiac tamponade, this tamponade physiology? Do you have a worsened pain with deep breaths or movements? Do you have pain that's reproducible with palpation of the anterior chest wall? These are all things you can ask about. Or you can ask the patient what causes the pain, what makes it better, what makes it worse. And maybe sometimes they'll tell you, oh, if I'm pushing things away, that makes it worse. And that would be more suspicious for costochondritis or some other musculoskeletal process. Now, as far as physical exam findings go, patients with cardiac tamponade, remember you can look for Beck's triad, so you can look for JVD, you can look to see if this patient is hypotensive, and you can auscultate to see if they have muffled heart sounds. And that's all things that can increase your suspicion for cardiac tamponade and tamponade physiology. So make sure that they don't have any tenderness over their anterior chest wall. They could also have a sternal fracture or rib fractures if this patient is a trauma patient. So make sure that those things are present or absent to raise or lower your suspicion for these various etiologies of their chest pain. And then as far as diagnostic tests go, again, you can get a point-of-care ultrasound, bedside echocardiogram to make sure that this patient doesn't have a massive pleural effusion around their heart that's squeezing down and putting them into tamponade. Make sure you can rule that out. So echocardiogram is actually really sensitive, meaning you can rule it out. You can rule cardiac tamponade out. It's very sensitive for cardiac tamponade. So if you don't see any, massive pleural effusion, they're not going to be in tamponade. That's a prerequisite for having cardiac tamponade, is to have all that fluid built up around your heart. However, it's not necessarily specific for cardiac tamponade. Patients come into the emergency department all the time with pleural, cardiac effusions around their heart, that pericardial effusions that are not in cardiac tamponade. So make sure that you understand the difference between those two, the sensitivity and specificity for echo at the bedside for cardiac tamponade. And then as far as costochondritis goes, it's more of a clinical diagnosis, but you can go ahead and get a chest x-ray to make sure that you are ruling out any sort of sternal fractures or rib fractures. You can actually use the linear probe on the ultrasound machine to rule out a sternal fracture. You can just kind of slide it up and down, and you can see the mismatch in the bone on ultrasound, and you can diagnose a sternal fracture at bedside without an x-ray, but you can go ahead and get that x-ray to look for any severe rib fractures as well. So thanks so much for tuning in. Remember, PETMAC, your pneumonia, your pulmonary embolism, your Boerhaave syndrome, your tension physiology from hemothorax or pneumothorax, as well as your throw up or GERD. Remember myocardial infarction to remind you of all your ACS process. Remember myocarditis to remind you of pericarditis and endocarditis. Remember aortic dissection. Remember attacks for panic attacks and anxiety attacks. Remember cardiac tamponade, and remember costochondritis or some other musculoskeletal process. So that's the mnemonic. Make sure you remember that for your workup. Make sure you don't miss anything that can kill your patients. And good luck studying. Thanks so much for tuning into this lecture. And remember, if you find these useful at all, please tell a friend. And remember that you can find all of our videos for free on Spotify as well. So we'll see you next time.